Good evening, good evening, good evening, ladies and gentlemen. I hope that you're doing well on this magnificent, marvelous, and motivational Monday. My name is Jason T. Mahoney, better known as the Motivator. Super excited to be here with you on the National Optometric Foundation webinar for the Eye Empowerment Program that they're doing. Typically, you see Dr. Timothy Brown, but everybody needs a vacation here and there. But he will definitely be back on the show in January, leading us in 2023 for the National Optometric Foundation. I'm super honored to be able to stand on this platform in his absence to carry on the torch. Tonight, we have an awesome conversation that we're going to focus on the interdisciplinary relationship between eye health as well as our regular physical health. As we're going into the holiday season, we want to make sure that we're healthy in all aspects. We have a really great panel lineup for us tonight, and we're super excited about that. But before we get started, I need you all to do something for me. I need you all to please like and share this. And then also, when you have a moment, go to the National Optometric Foundation Facebook page and like the page as well, where we'll be providing lots of information and resources. Also, visit the National Optometric the National Optometric website at www.nationaloptometricfoundation.com. Lots of information there. So again, we're going to go ahead and get started. Please like and share, because this is information that is so important and so crucial for our community, because eye health as well as physical health is extremely important for our community. So I'm going to bring up to the front our first guest speaker, which is Dr. Jacoby Cleaver. Dr. Cleaver, come on out, sir.
Hey, welcome. Thanks for having me. And Jason, you're absolutely right. We cannot get this show started without wishing Dr. Tim and Dr. Sharita Brown happy anniversary.
Yeah, happy anniversary.
Rating it up in New York per the Facebook post and pictures that we've been putting online all day. So that's great.
Absolutely. So, Dr. Cleaver, you're bringing us greetings from where?
Oh, I'm fresh out of Texas, man. We're out of Houston, Texas.
Where's your hat, man?
Oh, no hat tonight. No hat tonight.
It's
semi-casual tonight, right? But I did.
Good deal. You do have the jacket. Good deal. So listen, so we're going to go ahead and get started. So Dr. Cleaver, you have the forefront. So I know you're going to have a presentation with us tonight to really set the foundation for this. And again, I'm asking everybody to tune in. Please like and share this, because again, this is some really great information that we're going to get for our community, because our communities are suffering at such high rates and lots of disparities. So we want everyone to tune in to really focus on this eye health tonight. So Dr. Cleaver, you have the floor.
Perfect. Thank you, Jason. So just a little introduction for myself. My name is Dr. Jacoby Cleaver. I'm currently on staff at the Baylor College of Medicine here in Houston, Texas. But I don't practice on main campus. I practice at a community health clinic, the Martin Luther King Community Health Clinic to be exact. So, I love all things about the eye, but my bias is towards the front of the eye. So the anterior seg, the cornea, everything in front of the lens, so to speak. But when I was putting this presentation together, I wanted to touch on some of more of the high level aspects of it, but then kind of break it down into some of the more common things that I see in clinic and some of the more common questions that I get when I'm in clinic. So hopefully this will be a pretty fun presentation, and it won't be too heavy on the scientific part of it. So the cornea, the basic, we can hit the next slide. So the whole purpose of the cornea is to be a clear medium that allows the light to enter the eye and focus on the back of the eye, which is called the retina. Excuse me. The cornea also has refractive power too, so it also bends the light. So what you see here is just what we would see if I was looking back at the slit lamp, just the front surface of the cornea. And the cornea is comprised of 5 layers: the epithelial layer, the Bowman's layer, the stroma is the very thick band layer that you see right there in the center. Right behind that is the Desmond's membrane, and then to close out the corneal layers is the endothelium. Next slide. So the cornea is completely avascular, and I don't want you guys to get too bogged down in this picture here. But the cornea is avascular, and it has to get innervation from somewhere. So maybe some of you guys are familiar, maybe some of you guys are not familiar, but this will come back up towards the end of the presentation. The trigeminal nerve. So the trigeminal nerve has both, and that's the brown structure that you see over there to the left. The trigeminal nerve has both sensory and motor functions, but this is more of a sensory nerve. So the motor function of this nerve is extremely small. So from the trigeminal nerve, it branches into, it gives off three branches. Excuse me, I'm sorry, I got a little congested here. It gives off three branches. It gives off the ophthalmic branch. That's where we're focused most of our energy yet tonight. The maxillary branch and the mandibular branch. The ophthalmic branch then branches into three other branches: the frontal branch, the lacrimal branch, excuse me, and the nasociliary branch. The nasociliary branch is what actually supplies the cornea with the innervation. So on the picture that you see to the right, as the nerves are piercing the eyeball, the structure, it kind of bleeds, kind of goes up through the stroma where it joins with other bundles, and then that's where we get the nerve intervention. So the front surface of the eye is completely clear. There's no, so to speak, there's no nerve endings on the very front of the surface, but right below the front of the surface where you get all the nerve endings. And just a fun fact: the cornea is one of the most sensitive structures in the body. So any insult to the front surface of the cornea should give you a tremendous amount of pain. Next slide. So we'll just get into some of the more, well, this is not a very common condition at all. And at first, the thought was that epithelial basement membrane dystrophy was due to familial, like it was inherited and passed down through bloodlines. But more recent research indicates that this is more along the lines of degeneration. So what you see here is when we flash the light and it bounces off the back of the eye, the retina, and it gives us this orange glow, so to speak. So that kind of highlights any defects on the anterior surface of the cornea. This is at the very, very, very first top layer, the epithelium of the cornea. And this goes by a bunch of different names. MAP dot dystrophy. And if I could see the comments, I would ask, what would you consider this? Exactly. It looks just like a fingerprint. So this also goes by fingerprint dystrophy as well. Now, a patient may have this lifelong and may not have any symptoms at all. But as this progresses, sometimes it will progress. As it progresses, you can get blurry vision and those kind of things. And I don't want to get too much into the treatments of those things, of the blurry vision and recurrent corneal erosions to that matter. But, a very treatable condition. It can be pretty frustrating if you are the patient and you're waking up. Because remember, if you're starting to get these recurrent corneal erosions, you're going to get a lot of pain. This is a lot of pain for the patient. They're not going to be happy about it. And then they're going to almost want to see you immediately, right? So just kind of keep that in mind. Next slide. So Fuchs endothelial dystrophy. And let me just preface this by saying there's no small topics in eye care at all. So, like I said, some of the topics that I'm going over isn't the end all be all. Like there's a handful of corneal dystrophies broken down by layers, sections, and I'm just kind of touching on the ones that I may see a little bit more frequently in clinic. So this typically manifests in the fourth decade of life, so anytime around 40 or later. And what's happening here is that the endothelial cells' main purpose is to keep the cornea dehydrated. That means keep any fluid, any liquid out of those layers. So what happens is sometimes as we age, the endothelial pumps don't function as well as they should. So instead of keeping the water in, the water is starting to seep through. And then what you see in the picture on the right is that, my left, is that the stromal, the center section, the center layer of the cornea starts to become swollen. And this affects vision. So, for the students that's listening, one of the telltale signs is the patient to come in and say, well, my vision is blurry when I first wake up in the morning, but by the afternoon, it's a lot clearer. I can see a lot better. And what's happening is that those pumps are working to, when you sleep overnight, the fluid kind of accumulates. But when you wake up, the pumps start working to get the fluid off. This occurs in stages. So, the earlier stages, the patient may not be as symptomatic, but in the later stages 3, stages 4, then the patient's very symptomatic, and at that point we may need to start thinking about surgical intervention with the corneal specialists, our ophthalmology friends. And just a fun fact, this Fuchs endothelial dystrophy can occur in kids. It doesn't happen very often, but it can occur in kids. But most often, if you see this, it will be someone of adult age, 40 years old or older. I've never seen this in a 40-year-old to speak of that I know of, but anyone I've seen this in has been 60s, 70s, and older. Next slide. All right, so this is a comparison slide, and this is just us touching on corneal deposits. All right, for everyone listening, the picture to my left, the white ring that you see in that cornea, I get asked about this all the time, all day, every day. And the patients typically ask me, Doc, am I going to go blind from this? The short answer is absolutely not. What this is just an accumulation of lipid deposits within the front layers of the cornea. It stays in the periphery, so it won't move towards the center, so to speak, at all. So I tell my patient, hey, it may get a little darker, but it's not going to affect your vision at all. And usually the correlation, at least in my practice, the correlation isn't always 100% that if you see this, that the patient does have cholesterol. But if it's a new patient to you, if they're just establishing care with you, then and they never had blood work with a primary care doctor, this may be a good sign to get some blood work done, and just basic labs. I'm talking, CDC, blood count, lipid panel, those kind of things. Now, the picture next to it is indicative of a very serious condition. So it gives you this brown appearance because you have this is actually copper deposits within the front within the layer of the cornea. So copper deposits within the body is a very, very serious condition, and it can be known as Wilson's disease. And I can think of two patients, one I've actually seen a couple of weeks ago with this. And this isn't my patient per se, but this picture is pretty identical to what my patient looks like when he comes in. Now, I work in a community clinic, so the likelihood of me diagnosing this firsthand is very, very small, just because they would have established a primary care doctor and whoever else that they needed to see. But I have gotten referrals to do my eye exam and either confirm or not confirm the presence of these copper deposits. And this is a genetic disorder. And you guys, I don't know how to say it other than this is a pretty debilitating condition. My patient, he's a great patient. It's just kind of hard to see him going downhill, so to speak. But he's a great patient. He comes I see him about every 6 months. So just the difference between that. The white deposits is probably not going to give you much of anything at all. But if you know someone or you see someone with these brownish, reddish deposits, then that could be serious, indicative of a very serious condition. Next slide. So I know we have a nurse on the panel with us, and she can probably shed a little bit more light on this than I can. But what we have here is deposits in the front layer of the cornea due to amiodarone. And amiodarone, as we know, is a blood thinner used for those who have heart conditions. So now, what does this mean? If I say it in clinic, it doesn't necessarily mean anything at all to me. Especially if I can confirm that the patient is using amiodarone. Now, I'm not in a position to stop the amiodarone, and nor would I, because it's keeping the heart from working as hard as it should be, right? So when I see this, I usually just tell the patient, yeah, you got some corneal deposits. The patient is completely asymptomatic with this. I don't complain about nothing, and then it makes for a cool picture. I usually take a picture and I show it to them. But the fun fact about this, the minute they stop the amiodarone, the deposits will disappear. They will dissipate. So that's a good sign. But like I said, other than just seeing it, it makes for a cool picture. It usually doesn't have a lot of clinical value, so to speak. But amiodarone is probably the more common condition that may cause this, but it's not the only one. There's other, and I want to make sure I state that there's other systemic medications that can cause these same type of deposits. And it's called whorl keratopathy because it just looks like a whorl. So it may be kind of hard to appreciate in this picture, but that's exactly what's going on here. Next slide. So this is actually a patient of mine, and I have her looking down in the down view just to kind of highlight the bulging of the cornea. So the cornea normally looks like a dome. In some patients, that the cornea may start to, it looks like a dome, but in some patients, the cornea may start to present as a cone shape. And by doing so, that definitely greatly affects the vision. Now, some patients are affected more so than others. If I'm not mistaken, this patient here was okay with being corrected just with glasses. She wasn't interested in contact lenses or anything at all like that. But there's no real hard reason for why one develops keratoconus. Now, thought may be if a patient has crazy allergies or seasonal allergies, whether it's pollen, ragweed, whatever's in the whatever's in the air in your respective part of the country. And this actually may come from rubbing the eyes quite a bit. That's one of the theories. Like this is a mechanical force causing tension on the cornea, which causes it to bulge out. Now, it doesn't happen like it's a progressive condition, but it doesn't happen overnight. Usually, it kind of builds up to this stage. But like I said, I have a good friend that has keratoconus, and he does well with just specialty contact lenses. But like I said, in the case of this patient here, she wasn't interested in wearing contact lenses, and if I'm not mistaken, she achieved some pretty good vision just with her glasses. But also, I want you to guys, and this is not part of this, so to speak, but also pay attention to the eyelids and the skin below the eyelids, and you see how dark it is as compared to the skin around her cheeks. So that's very indicative that she's probably been rubbing her eyes chronically since, who knows, as long as we can both remember. So these are kind of like the telltale signs. And atopic keratoconjunctivitis may cause keratoconus, which is which is caused by atopic dermatitis, which is a very frequent condition that we may encounter quite a bit. So usually, and this is not to be confused with eczema, it's kind of around the same lines, but not quite, not exactly. But like I said, there's if glasses and contact lenses don't work, then there are surgical procedures. But with surgery comes long-term care, risk of rejections, and then constant follow-ups and medications, and to keep the cornea from rejecting itself, so to speak. All right, next slide. Now, this is very common here. And back in the day, they used to call this surf ride. So meaning that surfers would go surf, and then they would, for being in the salt water, off in the ocean and everything, and constant exposure to the water and the sun rays and that kind of thing, you would develop a pterygium. And this is exactly what this is. This is very, very, very common. So what's happening here is that the growth, which started onto the conjunctiva, which is the white portion section of the eye, grows onto the cornea. Now, in this patient, he was still able to achieve pretty good vision with just spectacle correction. But some patients, as it grows towards the center of the eye, then there will need to be surgical intervention performed by the ophthalmologist. At least in my clinic, the criteria is pretty stiff as to who will do the surgery. I mean, as when they will do the surgery. So they look for a certain amount of astigmatism. The vision has to be decreased by such amount, and there has to be like pretty much some loss of function, at least that's detrimental to the patient at that point. But more often than not, then these are pretty benign conditions, and I just educate to wear sunglasses when you're outside, frequent lubrication drops, try to stay away from dusty, sandy environments whenever possible. And then we'll just keep an eye on it. If we need to refer to for surgery, then we definitely can. But I tell the patients, hey, if your vision is excellent and the only issue you have with it is cosmetic, which I can see, which I definitely can appreciate, but let's just keep an eye on it for sure. All right, next slide. All right, so I'm not sure how big this shows up on your screen, but right there above the pupil, the dark part of the eye, there's a small metallic foreign body. So I'm never, I don't know how to say it. I'm never impressed when I see these when they come into the clinic for one reason, because whatever job that patient was performing before they came in, they wasn't wearing eye protection. So these, depending on what kind of job you do, and I usually get this from a lot of my patients work in landscaping or construction or something along those lines. So when I see these, like I said, I'm never impressed, and I just wish that the patients would wear more safety protection when they're out on these job sites, because these, and even in this case, this was removed fairly easy without any complication. There was a little scar left over, but it's not going to affect his vision at all. But in cases, I have colleagues that's seen these where a patient was grinding metal on metal. The force from the grinder was enough to propel that foreign body actually through the front surface into the eye and get lodged into the retina. Now we're talking about something that requires the patient to go into the operating room for, and we're talking about almost immediately. So, with that being said, the way you approach these things is a lot different. So this is going to happen. Usually it happens after hours. This is an ophthalmologist, and when this is happening, this is stat. The ophthalmologist is doing whatever they can to save the eye, and they got to get that foreign body out of there because it also lends you to infections and that kind of thing. But the take home from this is, guys, whatever you're doing, and I'm guilty of it as well. Like even if I'm cutting the grass myself, and I don't wear, may not always have on safety glasses, guys, you could. This is totally preventable, So whatever you're doing, please put on those safety glasses, safety goggles, whatever you're doing, because like I said, I can probably speak for many of my colleagues. We're not really impressed when we see these in clinic. Like it's cool to remove them. It's cool to educate, but if we can not do these in clinic, then that would be great. Next slide. All right, so this was a patient that I had who had an HSV, stands for herpes simplex virus infection of the eye. Now, let's back up a little bit. We know that there's two types of herpes, and we'll just go. Type 1 is above the waist. Type 2 is below the waist. Type 2 below the waist typically isn't the cause for this ocular condition here. So, and I can't remember. I won't quote the exact numbers because I can't remember them offhand. But at some point, you guys, you have been exposed to HSV1. And hey, don't look at your partner or whoever else, don't look at your partner and whoever else and blame them for exposing you. Typically, if you've ever been kissed or you've done the kissing, you've probably been exposed to this. This is along the same lines that develops cold sores that you would get on your lips. Same thing. Usually what happens, and then we can kind of go back to, we don't need to physically go back to the first slide, but what happens is that the initial infection is subclinical, which means you get infected and it doesn't present as in any specific way. What happens is that virus travels back to that big trigeminal nerve that we spoke about in the first two slides. It just stays there. It just sits in the trigeminal nerve and it just lays dormant. And for whatever reason, in some people, it reactivates and it comes back and it hits this front surface of the eye, and it's a live virus at this point. So what you see here in the greenish area isn't ooze or gunk or anything. That's from when I stained the patient, and it highlights the dendritic ulcer. So this patient was in an incredible amount of pain here. And what's happening is that this live virus manifests as a dendritic open ulcer, and we have to treat it almost immediately in order to give, not so much to get rid of the infection, but also to help the patient manage that pain. So this is a very manageable condition. For the practitioners that's listening, you do have to be cognizant of the patient's systemic conditions, mainly kidney functions, because if you're prescribing those oral antivirals, you kind of have to make the adjustment with the doses. We also can treat this with topical antiviral drops. My issue with in my experience with the topical antiviral drops is that, one, not many pharmacies carry it on hand, that they typically have to order it and it takes a couple of days to get in. And two, the frequency of the dosing is quite a bit. So one of them, you almost have to dose every hour up to 9 times a day. That's quite a bit. You can almost guarantee that you're going to get some kind of front surface toxicity from dosing a medication that much, which was the case in point with this patient. So we got we got rid of the dendrite, but now he has this crazy dryness and SBK type lesions on the front of the eye. Now that we have to contend with, and this patient did have some kidney conditions. So just to be on the safe side, I did on top of that topical antiviral, I did do an oral antiviral, and I followed him pretty closely. And he was a great patient. Unfortunately, he passed away a couple of years ago, but he was an extremely well patient. But what I'm seeing now, and even in our OD communities, that these infections are starting to become more prevalent in kids, which is a telltale sign. Now, you guys take that as you may, but this is one of the things we have to look out for. I even had a friend who called me and was asking me about a friend of hers, and just based on the age of her friend and everything, I said, "Oh, I said, I bet you lunch that is HSV, epithelial keratitis." So the short story of that is that I did get my lunch. So whenever he went to the optometrist and he was diagnosed and treated, and he's doing well. He's doing well. Okay, next slide, last slide. All right, so I included this slide not so much as to speak of either one of the diagnoses, just kind of some of the things that we've seen on social media within the recent weeks. And these are great discussion pieces, discussion topics for our current optometry students. And plus, anybody who's on Instagram or social media, I'm sure you've probably seen this and come across this in some aspect. But if you just kind of peruse the comment section, everyone is diagnosing and giving their 2 cents or whatever else. But the only reason I've really included this because as optometrists, eye care professionals, this is an excellent time to educate though about these conditions, about the importance of eye care and ocular health and those kind of things. Now, I believe ESTG, he said it was a traumatic cataract. So um, that's what he said. He said he was going blind from a traumatic cataract. If that is true, then they should be able to, the cataract specialist should be able to take care of that. Now, the young lady on the other side, and Miss Nurse Hayes asked me about her tongue. Well, we're not focused on her tongue in this one, Nurse Hayes, but the what we want to focus on is that this lady. I think she's from Australia. She tattooed the white parts of her eyes. So with that, which we will probably never see here in the United States, just due to the FDA, right? But this happened in Australia, and I think what is the deal? The title reads that she's starting to lose her vision from that. So some you almost have to weigh the risk and benefits, and in my opinion, there's no benefits to what she's done. It's just all risk. So she's lack of a better phrase, and I hate to say it, she's going to permanently lose her vision, and her life is going to be greatly affected after that. For the rest of her life and the rest of her, I believe she had a young child, and actually, if you read the article, you can just Google it. If you read the article, the young lady here mentioned that her daughter tried to tell her not to do this, and she went ahead and got it anyway. In fact, the daughter told her, I can't imagine that the daughter's any older than 12 or 13 or something, but she said, Mom, don't go do this. You're going to lose your vision. And this is exactly what's happening. So I would rather be on the other end of this and educate patients as to why this is a terrible idea, as opposed to being on the end that says, well, I told you so. Because this is detrimental. There's no coming back from what she's done. And I can't even imagine the amount of pain that she is, on top of being that she can't see. So with that being said, we know that the vision is one of our most precious senses. And then just imagine if you lost your vision, you pretty much lost a lot of your independence, quite a bit of it, right? Now we're talking about driving, seeing, things that we probably take for granted, right? So, just be mindful of these kind of things. And like I said, I wasn't here to speak on these two cases specifically, but just highlight how these cases become prevalent on social media, and it gets everyone to talking, and they're good discussion pieces. All right, I'm all done.
Awesome. Thoroughly enjoyed this presentation. Dr. Cleaver, I was intrigued, and you have a humor about yourself in your presentation, which I thought was really, really cool. Especially when you talked about the herpes piece. And so, with all jokes aside, it's good that the listening audience were able to hear us that is real. And I think sometimes when you kind of mention that about the exposure, and so someone go to their partner, what have you, and now you having a conversation, and so it's kind of just open a lot of things. So I appreciate that.
Yeah,
So
before we bring the other two on, I have to tell this story. So, and I've been in practice for about 11 years. So, in the beginning, I would be very careful with how I phrase questions, right? But we ask questions in order to get the information we need to make the best decision possible for the patient. So, I mean, I didn't include it on this side, but I had a patient a couple of weeks ago who came in with he went to see his primary care doctor, and the doctor called. I work in a big clinic, so the doctor called me and said, "Hey, Cleaver, do you mind seeing somebody?" I said, "Sure." And she said, "Well, I just got to warn you, it's real bad." I said, "Okay, I've seen bad. How bad could it be?" He comes down, and he's wearing sunglasses. He takes off the sunglasses, and it's the worst bacterial infection that I've ever
Wow.
seen. And we'll bring on Dr. McGee here in a second. But anytime you see this type of infection, you can't mistake it for anything else. It's only one thing, right? And we do the testing. Not that I needed to do any testing on my end, but the primary care needed to do testing on her end to see if we needed to add any systemic medications, right? So the long story of it is that he had a gonococcal infection of the eye, gonorrhea infection of the eye. Now, you guys, you use your imagination about that, but we put a topical antibiotic on top of a systemic antibiotic, and it cleared them right up. But to your point, like, you have to have these conversations with your patient, because now. And I'm not making jokes or anything about it. I do want my patients to feel comfortable with speaking to me. But I did ask him, "Hey man, when he came back to say, hey man, did you have a chance to discuss this with your partner?" And he said, "Yeah." And short of it was, now they're broken up. So you take you do what you got to, but but this is important, because if she was infected, or if he was infected, then there's a good chance that she was infected, and then whoever else was infected. So these people need to be treated. And
Exactly.
the crazy thing, as far as the CDC is concerned, before COVID got crazy, the CDC used to update every single year how you treat gonorrheal infections, because it changes every so often. You hear something about a superbug or something like that. If that superbug becomes prevalent and it's not responding to any of the medications and drugs that we have now, man, we're in trouble. So that's why you have to have these conversations, for sure.
Exactly. And you said something really key, and I'm gonna bring up the two panelists out. But you said something key. You talked about being honest. That this is important. That when patients come to see their doctor, or whomever that patient's coming to see as their healthcare provider, their social worker, whomever, that they need to be honest. Because you can only receive the treatment that you need if there's some honesty. So to our listening audience, if you have any questions, we're going to ask that you put them in the comment box, and we'll make sure and acknowledge those. Or if you just want to give any hand claps or accolades during this presentation, just do that. So Dr. Cleaver, we're gonna have a little bit of fun tonight. We because you already done started, okay? So we have two excellent individuals that are going to be joining us. The first is going to be Keisha L. Hayes, and Keisha L. Hayes is a nurse. She's a motivational speaker. She's a transformational leader in healthcare, and just an expert in aging as well. And so she's going to come to us and talk a little bit about just that aging as well. And then also during the holidays, as we all know, we get the long eyes and we want to eat all the time. But how does that unhealthy eating impacts our eye health, right? And so she's going to talk about from that particular perspective. So Keisha, you can come on out. And then next, we're going to call Dr. Brianne McGee. You mentioned her earlier in your presentation, and she was back in the back smiling as well when you were talking about some things. And so Dr. McGee is an optometrist as well. And so what we're going to do tonight is we're just going to talk. But before we talk, I just want to ask Keisha first, and I'll come to Dr. McGee. Keisha, is there anything that you want to say in regards to being in the background from a nurse perspective, listening to Dr. Cleaver's presentation?
First of all, hi, and I'm sorry, my mind is going everywhere with when he mentioned, he's so funny. When he said, I can imagine your imagination when I'm talking about the eye disease. And yeah, I went there. But anyway, and I'm sorry I said what I said about the tongue. I didn't know that you saw my chat in the box. But he mentioned something about amiodarone, and yeah, that's a medication that's used to treat irregular heartbeat, and sometimes it can cause fatty deposits. So I just wanted to state that. But also, the fatty deposits can come from having high cholesterol or bad cholesterol in your diet, such as the red meat and the dairy products. But anyway, I just wanted to say that was a great presentation, and you did well.
Thank you. Dr. McGee, anything you want to share before we kind of jump into this discussion here for tonight?
Not a lot, but shout out to you, Dr. Cleaver, for a great presentation. Thank you for representing. Thank you, Jason and Keisha, for this opportunity to be here and have this conversation tonight. So I'm excited.
Awesome. Awesome. So our first question for this evening is that when we think about eye health, right? Eye health and that physical health, that interdisciplinary piece tied together. Why is it so important that when an individual goes to their doctor, that they make sure and get that comprehensive clinical exam, where it's your eye, your feet, your toes, whatever you need to get checked, right? Even your diet. So why is it important for that to happen? And so, Dr. Cleaver, you've already kind of opened the door for us, but I'm gonna go to Keisha and Dr. McGee, whoever wants to go first. But why is that so important for that comprehensive exam? And some people may just want to go to the podiatrist, or some people, but people don't want to get that comprehensive piece. So why is that so important to get those comprehensive exams each year?
It's very important because when you go and get the comprehensive exams, you get labs drawn. And so when you get labs drawn, it can tell you exactly what's in your system. And we know that you need vitamin A and other things to make sure that you reduce any of your vision problems. So your labs are very important for the doctor to be able to see what might be hidden that you don't know about. So also your diet, you could talk about that in your comprehensive exam, because of course your diet affects your eyesight. And if you're not drinking a lot of water, that can show up as well. So it's very important that you go to the doctor, get these comprehensive exams to see the things that you can't see on the surface. I would say that.
Wow. Perfect. Dr. McGee?
Yeah, and to echo that, I agree. But one of the reasons why I pursued optometry, I actually did a summer internship at I think it was the University of Nebraska Medical Center, UMNC, during my junior year of college. And I shadowed an optometrist while I was there. And one of the things that has lingered with me since then, many, many moons ago, is that optometry, we not only save eyes, but we save lives. And at the time, I didn't really understand that, because like many people, especially patients, would think, oh, just go to the eye doctor just for glasses and contact lenses. But really and truly, there's so much, like Keisha mentioned, that's beyond the surface, that what we do and what we see. And like Dr. Cleaver, through many of these cases, yeah, we may see presenting signs for various systemic diseases or ocular diseases that present, and that sparks that investigation piece for us to go ahead and ask additional questions or seek out additional tests where we can rule out various diseases so that we at a diagnosis. But I also think that the most important part of your patient exam is patient education. If we want our patients to comply, we want our patients to come back, we want our patients to listen to what we're saying, the education piece is key. So this is where we bring home what it is that we're talking about and what it is that we're doing. Because I see students, and I always say, okay, you go in the room and tell a patient they have glaucoma. The patient gonna go home and say, oh, they told me I got the glauc. I gotta go get this. I gotta go get. They don't understand that. And I hate when people say, oh, dumb it down for people. No, we want to educate our communities. We want to empower our communities. We want to build medical mistrust. We don't want to build medical mistrust. We want to build medical trust. And also we want to empower our patients. And then also we want them to take that information and go to their communities and spread that information. I can't tell you how many people don't know diabetes can affect the eyes. And when I tell them that it can, they're like, wow, really? This is why I'm going blind. So you telling me I got to put my bread down? I'm like, yes, Mr. Jones, put that bread down, But also it allows us to connect with our patients, because they see that we not only have their vision and their eye health, but we really caring about their lives. And I can go on and on and on about just stories, countless stories that we see. And I know many of you in healthcare, y'all see these people every day, have those testimonies where people will come and they'll tell you like, hey, doc, thank you for, saving my life. So, yeah.
And you mentioned something, Dr. McGee, that was very important. investigative. When you go to a comprehensive medical, appointment, investigation is what really your provider is doing. They are getting to the bottom of what it is that's going on. And I love when we can go to physicians who, will just dig deep and find out the underlying causes of what's happening, as opposed to just treating all these different things and not knowing. And the trust part is really necessary. When patients come in to the doctor's office, they need to have someone there that's listening to them, not rushing them. I know, there's a time frame of when we have to have these appointments scheduled and when we have to get to the next person. But if you're not listening to your patient and what they're saying, then you're going to miss how you're going to help, with their situation. So it's a, two-way street, and education is really important.
Dr. Cleaver, I saw you unmuted.
Yeah, I was just going to agree with that. Absolutely. And I would say two of the most misleading phrases in medicine is that I feel fine is one. And then specifically in optometry, I see fine. We know that vision doesn't always correlate to the health of the eyes. And I'll just share this story, a personal story about my father, who was going to the doctor for various conditions, and he would come back and report to my brothers, my siblings, and myself, and then we would ask him all the questions, and then he said, "Well, I don't know," and then I would say, "Well, why didn't you ask?" And then he said, "Well, I'll ask the next time I go." So I just happened to be in town one time, and then I went with him, and I was asking a bunch of questions, and then he told me that I couldn't come back. I couldn't come back. I can't go. He told me, I can't go. You can't go back to the doctor with me, Kobe. That you asked so many questions. I said, well, if you ask, then I don't have to. I don't have to be here, and you can just report back. So he went to the eye doctor once, and he went in and he told the eye doctor, and he was actually, this guy was actually my eye doctor when I was younger. He told the eye doctor, he said, "Doc, I need you to tell me exactly everything I need to know, because Kobe's gonna ask me when I leave here. He's gonna call me the second that I leave. So I need you to explain this to me." And that kind of goes back to what Bree was saying about educating our community. Like, you kind of have to advocate for yourself. And I tell patients all the time, hey, you come in here, you see in 2020, you don't need anything, perfect. I still want to see you in a year. What else are you doing? I had a mechanic one time. He said, "Oh, this is like getting your registration every year." Yeah, something like that. Just come in and if there's nothing going on, perfect. And then we'll see you back in a year. But you don't need a reason to come in and see me. And this should bode well with other aspects of medicine too, right? And then I know we briefly touched on diabetes, but in my clinic, if you diagnose with diabetes and you see the primary care doctor, you see the podiatrist, at some point you had retinal images done, you see me, you go to the ophthalmologist if need be, you have a clinical pharmacist, and at some point you see the dietitian or the nutritionist. That is a lot of going here and there and everywhere in between, right? So I want to end off by saying this, and then I'll be quiet. Like, if you neglect your health now, you'll be forced to deal with it in the future. There's no way around it. There's no way around it. I just turned 40 this year. 20s, I was invincible. 40, I go to the doctor every time I need to go to the doctor. It's just one of those things. Like, nobody here is going to escape Father Time. Nobody is going to catch up to every single body. And then you add on that if you have a family history of said conditions, then it just piles on. And then before you know it, I literally had patients that go to the doctor every single day. Man, you can't go to work. Like, who gonna let you go to work if you taking off all this time, right? And then they're upset about not being able to work, right? Then it just becomes this merry-go-round of appointments, despair. It's just tough to deal with. It's tough to see.
Right. Keisha, I know you wanted to tap in when you talked about, if you don't address those things earlier, what happens in that longer life.
Yes, so many people come to healthcare settings, and they just they ignore not only their bodies and what their bodies are saying, but sometimes they ignore what we as nurses or even their providers are telling them at the appointment. And then we see them later on after they've gone to a hospital visit, almost on the verge of death, actually, because they did not do the things that were told to them when we did patient education. And then sometimes they've let things linger so long, as Dr. Cleaver would say, and not listening to their body and, how it feels. And then it goes to something more detrimental. So it's very important. Your body will tell you what's wrong with it. It will say at least that it's not normal. It's not the way that it used to feel. And you have to pay attention to that.
And so, interesting enough, one thing, couple things that you all said that I really like. You talked about patient education, which is so important when Dr. McGee brought that up. And then I believe Dr. Cleaver, as well as Keisha, said as well, is that the provider has to also be engaged as well. So when you're in that appointment as a patient, you have to be engaged in your treatment as well as your doctor has to be. It's a partnership. And so it's almost kind of like if you show up to your appointment and you don't seem engaged, your doctor may meet that same energy, right? But so let me ask this. In African-American community, we know that there has been lots of mistrust in the medical arena because we know our history, right? And so, but when we think about a vehicle, I'm going somewhere with this. So when we get a new car, and if the check engine light cuts on, we make sure and take it to the car dealership and fix that check engine light. If the hazard light, if whatever's working, if the brake light cut on, we go and get that checked. So when we're driving our car, our luxury cars or whatever car we're driving, we make sure and get it detailed. And let's not talk about how we want to keep a clean car with some clean rims, right? But I'm trying to really understand what can we really do to educate our community for us to look at our body as that vehicle, to say that when those signals come on with our body, because our body will give us a check engine light. Our body's going to say, hey, something's not working. And so how do we change our mindset or help our communities change the mindset to say, hey, just like you take that car to the dealership and you shine it and do all these things with it, you need to do the same thing for your body because your body's check engine light is coming on. So how do we educate our community? And that's what our empowerment is all about, is that grassroots getting into the community and helping these communities, underserved communities, to decrease these disparities. So how can we shift the mindset of communities to look at their body as if same thing you do for your car, you need to do the same thing for your body when that check engine light come on. So whomever wants to go first, I see everybody's nodding. Just jump in.
I can jump in first. I think that's a very hard question. And the reason why I say that is because everybody drives different cars. And with saying that, I think it's important to take a step back and look at social determinants of health. And I remember going to school and, you're thinking like, oh, everybody's going to get their glaucoma drops. Why aren't they complying? Why aren't they showing up their appointments on time? Why aren't they doing this? Why aren't they doing that? But being in practice for a little bit of time now and really having the opportunity to understand that everybody that's sitting in that chair have their own story to tell and they have their own car. Some people walking, some people on the bus, some people, they're taking care of other people in their household. Usually men, y'all don't come to the doctor at all. So that engine light been flashed for months and car literally broke down. Then you have men who are caregivers, and we often we take care of everybody else before we take care of ourselves. And so I think humbly as doctors, it's important for us to keep all of those things in mind, that everybody's, when they come in and have their chance or they have obstacles or there's those barriers or those flashes. Because I know I'm mad when my lights go off on car. I'm one of the people with a car, it might just fall out, y'all. I don't know. I'm like the Flintstones, and I'll be like, oh Lord, I guess it's time. But I mean, again, I think it's very important to understand patients. And oftentimes with pregnant moms, right? Mortality, and nobody's believing them. They're like, oh, you a black woman, you're a brown woman, y'all got tough skin. But I want somebody to listen to me. And oftentimes we're ignored. People, we're faced with these biases, these stereotypes, and often the patients come in. I can't take time. Patients, nobody's ever sat down and told me this. Nobody ever took the time to investigate this or to just, just sit down and talk with me. You know what I'm saying? So patients want just that little bit of time to understand their car so we can clear exam, customize whatever it is that's going on with them, but not give them that one size fit all kind of care. The I want to mention is that there's so many stigmas around healthcare. So many people of color, we only go to the doctor when there's a problem for preventative health. Kobe mentioned, taking that time out early and, addressing the problem early on versus waiting to the last minute and really face it head on. My mom used to always say, when I teach kids, your teeth now, if you're not true to the teeth now, I realize to take the time to brush and floss and take care of our dental hygiene. But I can't go on and our communities because, just so many by other things that they face. And I love your analogy of understanding.
Dr. Cleaver, Dr. Keisha, what are your thoughts on that car, and what do we need to do to help educate our communities?
Definitely echoing what Dr. McGee said, and I loved it when she said we're all riding in different cars and we're all going to different destinations. So that was, I added the destination part, but that was powerful about the car because we're all from different environments and backgrounds. We all have different stories. You just don't know. What really opened my eyes was when I used to work in a community health center. And of course, community health centers, they serve underserved populations. And, they try to have comprehensive packages there so that people can get everything in one spot because of such barriers like transportation and not being able to pay for visits. Some people would come in and they would use our sliding fee scale based on family size and income. And, sometimes their visits would be zero actually to help them. But you just never know what it took for them to get to the appointment. And so when they get to the appointment, it's necessary for us as the professionals to make sure that they get an excellent appointment, and then that we're listening to everything that they are saying to us. And even if they meet us with a certain type of energy and they are not really telling us stuff, let's ask questions to help them open up and not have a projection towards them that will judge them based on the fact that we're different from them. Let's try to see what's going on with them and ask questions. And it goes back to one of the trauma-informed panels that we have. Instead of saying, what's going on with you, what happened to you,
Mm-hmm. Mm-hmm. Absolutely. Thank you. Dr. Cleaver.
Yeah, I mean, I can't add anything more than what these two distinguished panelists have added. But I just found when you're dealing with the community, and I had to learn this. Fear's a great motivator for some. It doesn't work for everybody. Education is a motivator that works for everybody. If you can just break down the condition, why, what is happening, and what may happen if we without compliance. But with that being said, I usually tell patients because we'll get patients that just kind of rattle off like problem after problem after problem after problem, and I just normally stop them and say, "Hey, man, I'm gonna see you again. We don't have to address every single thing today. Like this is an ongoing relationship, and we can schedule you to come back, and we can keep addressing these things into the future. But this is what healthcare is all about. This is a two-way street communication between provider and patient, and that builds up the trust. I have patients that tell me that they won't go anywhere else. No, I've actually had a patient tell me, and like I said, I'm an optometrist. I don't do any surgery. I referred her for cataract surgery, and she said, "Well, I just feel more comfortable if you did it." I said, "No, you won't. I don't do any surgery at all. You truly don't want that at all." But with saying that, and I know I kind of addressed, presented today with quite a bit of humor, and I do present to the exam room with that as well. But
Mm-hmm.
and I got this from a colleague of mine. The first few minutes of the exam, I, I don't care anything about why you're here.
Mm-hmm.
What have you been up to? How things have been going? You know what? Then after the few minutes of breaking down the barrier, or they can let down their guard. Then we can say, okay, well, what brings you in today, right?
Mm-hmm.
So get to know the patient before they come in. I'm not saying that you have to go back and ask them about how their mom and everybody else is doing, but hey, man, we coming out. We're going into the holidays. You got any plans? You been doing any traveling? Oh,
Mm-hmm.
how about, do you like the week? Have you seen any good movies? Like all that stuff. Like how's the
Mm-hmm.
weather? Even as corny as it sounds, how's the weather? Like that stuff works. Especially
Mm-hmm.
right? Like, oh, it's hot. But those things work, and an excellent conversation starter. So usually I take the first few minutes just to kind of chit chat, small talk, and it works.
It's like to me, it's like building a rapport, because technically, I'm a social worker by trade, and so it's building a rapport, because it's the idea of, I'm really about to get all of your business, about to find out everything what's going on with you medically. So I should do an icebreaker before I at least get to know you, before we dive into what's kind of going on. I think that's that relationship building that you're doing with your clients, with your patients. So we're almost at the time to wrap out. But I just want to have some fun before we do. What is your favorite holiday dessert? What's your favorite Christmas dessert? Dr. Cleve, what's your favorite Christmas dessert?
Mm, I don't know.
You know, everything? Well, we're going to come back to you. I was looking for something funny.
Let me
Keisha,
see.
what's your favorite Christmas dessert?
Sweet potato pie.
Okay.
Yes. Sweet potato pie.
Okay.
Really? Huh.
Yes.
um, okay. All right. So if my wife is making it, it's caramel cake. If my mom is making it, it's German chocolate cake.
So I'm going to get you in trouble on a live. Which one tastes the best? I'm just playing. I'm just
You're not
playing.
gonna do me like that.
Exactly. Dr. McKee, what's your favorite holiday dessert? I think Dr. McGee is frozen, but that's frozen with a beautiful smile there.
Yeah, we'll take it. Take it. She's in New Orleans, so maybe. Oh, I mean, I don't
Oh,
know.
she's in New Orleans and she having fun.
What's the go-to in New
Can
Orleans?
y'all hear?
We can.
Yeah,
We got you now.
Y'all say
What's your favorite holiday dessert?
Oh, I gotta hear this. I'm gonna have to text her after this and ask.
Yeah, you have to text after that. She's having bad signal. But the reason I asked about the favorite holiday dessert, I wanted to always twist it to some educational piece. I'm sure a lot of our listening audience during this holiday season are going to really be around family, just enjoying family. And when we do that, we kind of let our guards down sometimes, and we don't be focusing on our health while we're doing that. But what would Dr. McGee, what's your favorite holiday dessert?
Sorry, my internet was acting crazy. It's raining out here. I don't really like desserts, but I be liking to eat all the food. But if I had to pick a dessert, I'm gonna pick the pecan pie, because I'm gonna hide it and tell everybody that the auntie ate it that came late and but really I had put it on top of her. I won't tell nobody that.
Love it, love it. So as we wrap out, what is and during the holiday season, we still have a lot of medical things that are going on out here in the community. We still have to focus on our health while we're eating and having fun. So what is I would like for each one of you all to just tell one tip for our listening providers, that's something that they can do to ensure that when they walk into the new year after Christmas, they're going to be walking in healthy. So something that they can do while they're enjoying the holiday season, so they can walk into the new year healthy.
I would say that it's going to be a lot of buffets. The table's going to be spread, and the counter's going to be lined up with everything you can think of. So I saw on the CDC website one time that you need to outsmart the buffet. So instead of going up there piling your plate up, this high, start with the vegetables first and take the edge off of the hunger that you have. Because sometimes when you're hungry and you're ready to get into that nice holiday food, you just eat everything. So start with your vegetables so you can get full with those, and then limit yourself to other things, and keep moving too. Do some physical activity, walk with your family, and make it a family affair when you do so.
Cool deal. Thank you. Dr. McGee, what's that one thing that we can do during the holidays to have a successful, healthy 2023?
I always say moderation is key. And that applies to so many things. But as far as food, moderation is key. And then if you're spending time with your family, play games, play active games. My family and I, for Thanksgiving, we were playing, I think it's head, shoulders, knees, toes. You gotta grab the cup, and we do relay races. But I started to instill those games so that my family could burn off calories, because they'll eat a lot of food. And coming from the South, it's a cultural thing. So when you see the food and you see the buffet, your mindset is just to eat, 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 eat. But if you throw some kind of those fun activities in there, people don't realize that they're burning off all those calories. So gotta be sneaky with it.
I love it. I love it. I'm coming to you off of Thanksgiving, Dr. McGee, head, shoulders, knees, and toes. We're going to have water in the cup, though, because we're going to be drinking water. Dr. Cleaver.
I just add on what both of the ladies said. I find it that if you start off the day by making good decisions, then good decisions build on good decisions. They fuel further good decisions throughout the day. So I know I have family members that will go do the turkey trot before Thanksgiving, or they play football or something like that. Some physical activity to get started. So I would say go for smaller portions. And hey, we've been around family before. We all love the holidays, but we've had the holidays before. Like we know that that turkey and gravy and all that stuff. We know what it tastes like, but you can exercise some discipline, maybe smaller portions, be more active, and really more so enjoy your family more than you have to enjoy the food, I would say.
Got it. Love it. Enjoy the family more than you have to enjoy the food. Good. Listen. I want to thank you all on behalf of the National Optometric Foundation, and especially the National Vision, who sponsors the Eye Empowerment Initiative through the National Vision grant. And so we want to thank the National Vision for being sponsors for this, and the National Optometric Foundation and the National Optometric Association. Again, Jason T. Mahoney, better known as the Motivator, here standing in for Dr. Timothy Brown, as he and Dr. Sharita Brown celebrated their anniversary. Happy anniversary, Dr. Browns. Super exciting. We miss you, but we'll see you all in January, so y'all can take this great monument back. But a huge thank you to the panelists. I just want to give you all a virtual hand clap, and if our listening audience can get some thumbs ups and hearts as well. This has been a lot of fun, humorous, but educational at the same time. So we appreciate that. We'll be calling on you guys again in the new year. Please go to the National Optometric Foundation Facebook page, like the page, visit the YouTube channel, subscribe to the YouTube channel, as well as go to the Instagram page and like the Instagram page as well. And if you're feeling happy this holiday season, you can even make a tax deductible donation to the National Optometric Foundation. You can go to the Cash App, and Cash App is $ protecting the vision. Please go and make a donation. I see Dr. Cleaver's about to pull out his phone and about to make a Cash App donation. Dr. Cleaver, I will match whatever you're going to donate tonight. So again, make a donation. Again, helping the community see. And again, as Dr. McGee said, we're not just saving eyes, we're also saving lives as well. Have a happy holiday. Merry Christmas. Happy New Year. And we look forward to seeing you in 2023 as we continue with the virtual information session on eye health and overall health as well. Take care. See you in 2023.